morphology of each individual component and how that kind of affects the overall picture when we're looking at it in the physiological conditions. We're going to look at a few disease states, including MIs, electrolyte imbalances, and infections. Okay, that's the basic objective today. And then a systematic approach to 12 lead EKGs. What is an EKG? It's an electrical representation of the repolarization and depolarization of the heart. Abnormalities from the baseline represent either a chemical or a structural deficit that impedes the electrical impulses as it travels through the heart. Pretty simple. The conduction of the heart. So this is just a nice, simple way of kind of explaining. We're going from the, I get a pointer, I don't have to walk up to the screen. From the SA node coming down to the AV node and then down into the ventricles. Okay, the individual components. The P wave originates in the SA node. It represents the depolarization of the atrium. The standard amplitude, the height, is less than 2.5 millimeters in lead 2. The very beginning of all this is going to be a lot of numbers, so that when we look at other things, we can actually go back and say this is abnormal based on this. Just to talk about real quick, the slides have a lot of these numbers. I just printed up the very beginning of the slides, so if we need to refer to it, we can just jump back to that slide. So that's the main reason for the handouts. There's unfortunately a lot more. Standard length is less than, or that's wrong, is 120 milliseconds to 200 milliseconds. The standard kind of length. Actually, no, I'm sorry, I'm talking about pure interval. The standard length is 120 milliseconds. Sorry, I'm nervous just starting out. Repolarization of the P wave, we can't detect it because it's hidden in the QRS depolarization. So in other places when we look, we can see the repolarization of the QRS complex in the ventricles, but the P waves are hidden. Abnormal P wave morphology. Okay, tall peaked P waves. When we're looking at everything, when you're looking at the P waves, lead 2 is the best place to look. When you have these tall peaked P waves like this, it's indicative of right atrial enlargement. Okay, so the right side of the heart is enlarged for whatever reason. Widened P waves down here, you can see this is a bunny ear kind of P waves, is indicative of left atrial enlargement. Okay, and I rarely see true bunny waves, but you'll definitely see a kind of widened P wave in lead 2. So that's indicative of the left side of the heart has issues going on. Left atrial enlargement, late stage hypokalemia can also give you a widened P wave. Okay, inverted P waves in lead 2 is generally indicative of accelerated junctional rhythm. And so whatever it is, it's a depolarization that is not coming from the SA node. Is kind of retrograde and coming out. Okay. Examples of P wave morphology. I thought this picture was kind of interesting because when you're looking at a P wave, the first part of the P wave right here is actually the right atrium, and the second part is the left atrium. So that explains why you can get the bunny ears and those kind of things going on in that widening. Generally, the atrium is depolarized from the right atrium to the left atrium, as we see here. Examples of peaked P waves, okay? You can see how they're kind of pointy here. And this is in lead 3, but typically you're going to be looking in lead 2. Is indicative of the right atrial enlargement. Examples of widened P waves, down here you can see that we have nice examples of bunny ears going on. Okay, and that's lead 2, which is where you want to look. And it's greater than 100 milliseconds, 120 milliseconds like we said. I rarely see the notches, as I said a minute ago. You normally just see this kind of widened P. Okay, talk about that. Abnormal P waves continued. Inverted P waves, we can see that this is coming from someplace other than the SA node, that it's retrograde and coming up. Buried P waves, like this was an interesting one looking at it, you kind of walking it out, and this is where I love to use a piece of paper, make the hash marks and kind of walk it out, and you can see where you can normally get a little confused where things are going on. That's saying that this is most likely a P wave that's buried. Pearls. Look for, whenever you're not sure, make sure you're looking that they're the same shape. If they're different shapes and different morphology between each P wave and a QRS, then I'd be suspected that those are actually P waves unless they're right on the QRS. So similar morphology is generally going to go on unless you have, you know, WPW or those kind of things. Okay. Why are P waves important? Obviously, it allows us to determine sinus rhythm. It allows us to determine the communication between the top of the heart and the bottom of the heart. Helps determine atrial enlargement. Okay, PR interval. It's the time frame between the P wave depolarizing and the beginning of the QRS. The standard length is 120 to 200 milliseconds. If it's greater than 200 milliseconds, it's a first degree block. If it's less than 120 milliseconds, generally you're going to be looking for WPW, okay? Which in the field I don't think we're going to use too often. You'll also see with a shortened PR interval that it can be indicative of pericarditis. So the reason that you have this delay right here, that your P wave doesn't kick in and you go right into the QRS, is because you're allowing the blood to actually fill the ventricle. If it was right on top of it, you would have ineffective filling of the ventricle from the atrium. So there's a natural kind of slowdown pathway between the SA node into the from the AV node down into the ventricles. Possible causes of prolonged PR intervals is damage to the conductive tissue. Say they had a septal infarct or something going on here, the LAD is affecting the AV node. You can also get that, and I'll talk about this later, the actual coronaries, but there's a branch that comes off the right coronary artery that actually specifically feeds the AV node. Okay? Hypokalemia can also cause this, and benign with age. A lot of people, as they get older, just the heart isn't as effective and they have just underlying benign disease. So the three waves of a QRS complex, the first one is a Q wave, okay? It represents the septal wall depolarization. The R wave represents the ventricle depolarization. And then you have the S wave, which represents the depolarization, those arrows were supposed to stay on there, represents the depolarization of the Purkinje fibers. The Q wave, there's two different types of Q waves. The first one is the physiological Q wave, which is normal. Okay, a physiological Q wave, you're going to mostly see it in 3 AVF and V1. It's going to be narrow and it's going to be shallow. If you look here, and I'll talk about it in just a second, but actually I pushed wrong button. But a pathological Q wave is bad. To have a pathological Q wave, you need a few things. You need it in 2 concurrent leads. So say I have it in 2 and 3, then...
This is 2, cardiac arrest priority 1, 1386, go which way?
7, 4.
4 is going.
Concurrent leads, for example, 2 and 3, and then it's wider than 40 milliseconds, and it's greater. Now there's some debate. I kind of had one of my cardiologists look over this. The textbooks are saying 1/3 of the QRS complex. He was really saying, it's 25%. So if you go 25 to 1/3 of the QRS complex, who knows? Their textbooks in reality don't always mesh. But if you see something wide and deep, then you know that you probably have a pathological Q wave. This is not something that occurs right away. Okay, it can take hours to days to develop Q waves. You can. The lack of Q waves does exclude current ACS, but if someone says, I've never had a cardiac event, I've never had a heart attack, I don't have anything, and they've got these smoking Q waves and the inferior leads, you kind of know that they are wrong. So here's an example of a physiological. You can see how it's narrow and shallow. It's probably 15% of the QRS complex. Compared to the pathological Q wave, nice and wide, and I'd say that's about 40% of the QRS complex. So that's a kind of nice thing to look at and figure out. Examples of pathological Q waves. We can see right there, it's not horribly wide, but it's definitely a deep Q wave. Okay? Yeah, exactly. We got them at 3 also, so those are concurrent. And AVF had some Q waves too. And again, I just want to reiterate, this is not a current MI, this is a previous, unless the patient's sitting there saying, I've had chest pain now for 3 days. And you're like, this indicates cardiac history. The QRS complex. It originates from the left ventricle and then the right ventricle, which is important when we talk about bundle branch blocks, because that's why, you know, one bundle looks significantly different from the other bundle. Designates the depolarization of the ventricle, obviously. Standard duration is you're going to be less than 0.12 milliseconds. Greater than 120 milliseconds equals a bundle branch. Left bundle branch block. Remember, it goes from the left to the right. The left ventricle depolarizes first, but in a left ventricle, normal physiology, it depolarizes from the left first. In a left bundle branch block, because there's a block going on, the right depolarizes first. And you can see, you can see that we have a downward deflection and wide. I really like the steering wheel kind of theory for doing determining right and left. If you're sticking your arm out to turn, that's a right bundle branch because you're going to turn right. And you're always looking in V1. If your arm's down, you're going to be turning left. Very simple way to determine right and left bundle branch block. Everyone comfortable with that? Okay. Characterized by a QRS greater than 120 milliseconds. Downward deflection in V1. And a large S wave. And we're going to talk in a minute about S waves, but it's kind of that swooping kind of nature coming off the QRS, and it swoops out into the ST segment instead of coming straight up. We'll talk a little bit more about that in a few minutes. They can cause or produce the bunny ears, but the bunny ears are not the indicator of the bundle branch block. It's the widened QRS. Causes of the left bundle branch block, anything that can cause cardiomyopathy, okay? Aortic stenosis, ischemic heart disease, hypertension, anterior MIs. Treatment considerations. Now there's some kind of discussion now that I forget, the SAR starts with an S.
No metal circle.
I am losing cruise. So treatment considerations, new onset of left bundle branch with chest pain and clinical conditions correlated with MI, consider it as STEMI. Talking and working in the cath lab, we would always rather have you have a higher index of suspicion than a lower index of suspicion. It's hard in the field because we don't have old EKGs. We don't know if this is a new left bundle branch block. We don't know a lot of those things. But if their clinical conditions are correlating with, ACS, treat it as such, let the hospital know, and then they can make a decision on what they want to do. Okay? Right bundle branch block. The EKG looks otherwise normal except in the precordial leads. So we can see here it looks nice and normal in lead 1, 2, all the way down the left side of the EKG. But as we get into the precordial leads 1 through 6, you have a widening of the QRS. Now, because it normally depolarizes this way, it looks more normal. It's just a widened QRS complex. Okay. The left ventricle depolarizes first, so again, the EKG, the QRS looks unchanged. It is characterized by greater than 120 milliseconds. Again, using the steering wheel turn signal theory, it's got an upward deflection and large S waves in the precordial leads, especially in V5, V6. And T wave inversions in V1 through 3, you can see we've got the downward deflection of the T waves. Causes of a right bundle branch block, obviously right ventricular hypertrophy, pulmonary embolist, cardiomyopathy. Oh, there's one more. So the S wave originates in the Purkinje fibers. It represents the depolarization of the Purkinje fibers, and the standard height is greater in V1 and progressively becoming smaller as you go to V6 in the precordial leads. Large widened S waves in lead 1 and other EKGs can be suspicious of pulmonary embolus. And I'm going to talk later about this is S1, Q3, T3. It's if you have an S wave in lead 1, a Q wave in lead 3, and an inverted T wave in lead 3, that's indicative of suspicion for pulmonary embolus. So it's not the correlation. When I was writing this, we were dealing with a lot of pulmonary embolus in the cath lab. and every single one had it, but they're saying there's a 25, I think, % chance of a correlation, but I was having 100% correlation for like 3 weeks, which was like, huh. J point. It's the beginning of the repolarization of the ventricle. This is the point where we measure ST segment elevation or depression. So it's important to be able to find that J point to be able to say that. When you have a swooping S wave and those kind of things, it becomes a little more difficult. The isoelectric line is that line where no electrical activity is occurring. So right here is the isoelectric line, as you can see. This allows us to determine that baseline for elevation or depression. And there's also other things like if we have sagging PR intervals or sagging ST intervals are indicative of other disease states. The ST segment. This is the isoelectric period between depolarization and repolarization, where the heart is kind of, or the muscle, the cellular activity is kind of switching over to repolarizing, so it's kind of a slightly of a dead space. ST elevation, the pathology is generally necrosis of tissue, or it can be an inflammatory process related to pericarditis. Physiological variances. You can have a normal variance in juveniles and young adults. Important throughout all this, we have to treat the patient, not the paper, okay? The EKG is merely an adjunct to your clinical assessment. Without,
We're good.
we will see things that don't correlate with the clinical picture of the patient. There are zebras in this world where people just don't make sense. Some elderly females, postmenopausal, those kind of things. But in general, make sure that you're treating the patient, not the paper. So ST elevation is characterized by greater than 2 millimeters in V2 and V3 and greater than 1 millimeter in all other leads. I don't know what you guys are trained on. I had a few arguments with some cardiologists. Some said greater than 1 millimeter in any lead. But to me, I think that's too sensitive of an indication, where I left 2 millimeters in V2, V3. If the clinical picture is pointing to that this is a STEMI or acute coronary syndrome, and it is just 1 millimeter, I'd rather have you talk to the doc and say, hey, this is what I've got, this is how he's presenting, and so forth. And then if we activate the cath lab, personally as a cath lab member, I don't care. I'm going to come in, and if they turn me around midway, they turn me around. It's not a big deal. But remember that it needs to be in concurrent leads. ST depression, the pathology is ischemia typically. Non-ischemic issues are a lot of things, okay? We have DIGE, hypokalemia, ventricular hypertrophy, which we're going to talk more about later, hypothermia, tachycardia, mitral valve prolapse. The T wave, which was interesting when I was making this, I tried to find one QRS complex that I can continually reuse. When I was reading and doing a little study on this, this is actually a T wave that's indicative of ischemia. Because, and I'll talk about it in just a second, but the normal T wave should look like this, where you kind of have a gradual upward slope and then a steeper downward slope, okay? When it's belled like this, where you've got a gradual up and a gradual down, that's more indicative of ischemia. And I was like, well, I'm not going back and changing all my slides, so I'm just going to have to cop to it right now and tell you what it is. It represents the repolarization of the ventricle. It's upright in all leads except for V1 and AVR. Okay? If you have, downward deflection in any other leads, that is not significant, but it's indicative of something going on. And again, it's the same direction as a QRS, which is important. Morphology, again, like I was just saying, the gradual upslope and the steeper decline. Abnormal T waves can constitute almost anything. It is really, the list is astronomical of all the different things that can cause abnormal T waves, but knowing that they're there kind of peaks up your bunny ears of, is there something else going on that I'm missing? And as I was saying earlier, the symmetrical upslope and downslope can constitute ischemia. But that is such a subtle sign. I don't think, us flying or you guys in the back of the bus are going to be like, look at it's gradual, you know, so to me it's not really relevant for the field setting. Inverted T waves can be the result of myocardial ischemia, non-STEMI, possibly an old MI. Okay. It can also be, again, we're talking about that S1Q3T3. It can be indicative of a pulmonary embolism. Pericarditis, which is very uncommon. And remember again, V1 and AVL, the T waves are normally flipped. So let's talk about peaked T waves. Peaked T waves are tall, narrow, and symmetrical. We've all learned this. Peaked T waves, hyperkalemia. I'll tell you from my clinical experience working, 13 years as a nurse, that unless it's new onset hyperkalemia, you're rarely ever going to see high T waves. I can't really say that I've seen tall peaked P waves on any chronic renal disease. They possibly were there, but the ones that always stick out that go, whoa, it's always new onset, because the human body has an amazing ability to adapt. And again, that's just my experience. As I said, it's indicative of a high K. QT interval. I've got a nice, quick, easy way for you guys to cheat on the QT interval in a minute. Where it represents the time period between depolarization and repolarization of the ventricle. QTC is a mathematical formula for calculating what the QT is based on heart rate. So whenever you're looking at the EKG, make sure you're looking at QTC, because it's already calculating for that heart rate and what it is. Eyeball evaluation, the easiest way. Pick the most prominent T waves, okay? Find the QRS. If your T wave, the end of your T wave is less than half of your R to R wave, you're golden. So less than half of that kind of interval right here, you're golden. If it's greater than half, then you got some issues possibly that you need to be aware of. You know, are you going to suspect that they might go into torsades? Is there something else going on? Is there drug toxicity? There's a lot of different things that can cause QTC prolongation. But a quick, easy way in the back of the bus or an aircraft is just look at that R to R interval and make sure that the T wave is less than half. Okay? So right there we're golden. With a prolonged QT, you're at risk for R on T due to delayed repolarization and premature action potential. Risk for VT, VF, and torsades. Continue. So, QT interval continued. Demographics of prolonged QT. It's greater in females. It's greater in elderly. Medication that can prolong QT, Haldol, which we all love to give. SSRIs, thiazides, alcohol. Antibiotics is a big one. You can get a significantly prolonged QT interval from antibiotics. Amiodarone, obviously. Methadone, and I mean the list when I was looking at it, I was going to take up 6 or 7 slides just on the most common ones. So as our population gets older and older and takes more and more meds, guess what? We have a increased risk for QTC prolongation. Now, I think I rounded it to 450 milliseconds, anything greater than 450. The elderly and females, I think, is 460 milliseconds, and I think males and younger is 440 milliseconds. So I just picked one number for you guys to be able to remember. It's 450, just kind of split the difference there. U waves, not fully understood, and they're not very often seen here. But U waves represent the repolarization of the Purkinje fibers or additional repolarization of the ventricle. No one really knows. There's debate back and forth on it. And as I was saying earlier, before the class gets started, if you get 3 cardiologists in a room and have an EKG, they're going to argue over what causes what and all that. It's kind of entertaining to watch. Characterized by a sharp upslope. So if you remember in the T wave that you had a shallow upslope and then a gentle downslope. I had to hand draw this and I did a horrible job, but you get the general picture. And then a gradual downslope at the other end. Best seen in V2 and V3. Same direction as the T wave is the orientation. The slower the heart rate, the bigger the Q wave you're going to see. So a lot of times not a lot of times, you can see it in more prominently in bradycardia. You can get prominent upright U waves with hypokalemia. You also get ST depression and small T waves. With hypokalemia, it's important to remember that magnesium follows potassium. Okay, so if you have someone that's showing, these Q waves with some ST depression and small T waves, you can theorize that they have low potassium and that their mags low. And if their mags are low, they're also at risk for torsades again. So just kind of one of those things that make sure your ears kind of perk up and think about what else is going on in the picture. Hypothermia can cause U waves. And this one, I took some time trying to find this data. Why it had, you're going to see U waves and increased intracranial pressure. Pretty much what I came to the conclusion of, they don't know, but it's there. So there's something that goes on that is causing U waves to become prominent when you have an increase in intracranial pressure. The correlation is not, I could not find a strong correlation, but they have seen it. So it's kind of there for just kicks and giggles. I wouldn't, in your clinical practice, I don't think it has relevance, but I thought it was kind of interesting. I was trying to figure out why. Examples of U waves. So as I said, it becomes more pronounced as the heart rate decreases. Is that when we're looking at the bottom one, is that a U wave or a P wave? If we look, I was talking about the morphology earlier of the P waves. If you look, they're similar and they're rounded here. Okay, they've almost got a little peak here, where when you look at these, they're similar, but not similar to these P waves. But what is that?
So you would notice that there's two versus a very P wave. Correct?
Well, if I'm looking, oops, hold on, I'm trying to get that. If I'm looking at this, I see this upward morphology with a QRS. I've got an upward morphology with a QRS. I got an upward morphology, I think, looks with no QRS, so that makes me a little suspect. But when I look after the ST segment here, the T wave, that's much more rounded. That's much more rounded. So in general, that's a hard one. I'd probably want to look at a longer strip. But looking at it quickly, it's suspect. I don't know. But is that a U wave? That's something in your clinical practice. You're going to be looking at it and go, is this a third degree? What's going on? Is this a second degree type 2? But knowing about the U waves and kind of thinking about it. To me, I said the U waves are a little more flattened on top. It still could be intermittent, third degree. So clinical picture is as important as the EKG to me. All right, break time. I did that for you. Components of an EKG. We're going to talk about 12-lead EKG. Okay, there's three types of leads. This is review for everyone, but talking about the augmented leads is the most important thing that I'm kind of going to go over here. You have your standard limb leads, right arm, left leg, left leg. You have your augmented leads, which is the reason that augmented leads came about is because they couldn't figure out how to do a 12-lead initially, and that they did mathematical formulas to try to give different angles based on only having 3 leads. So that's where all these augmented leads came from. First one is AVF. It's the right arm, which is the positive, to the left arm, left leg, which is negative. And you can see it looks through the left ventricle, like that. So the next one is AVL, which is the left arm is the positive, going to the right arm and the left leg, which is looking through the lateral wall of the heart. Okay. And the last one is AVR, which is left lower leg or left lower limb going to the right arm, left arm. And as we look at that, that's looking at kind of the endocardium. Initially, I kind of called that the septum or the septal wall. talking to my cardiologist. He's like, it's mainly you see the endocardium. And I was like, okay. They don't really understand how you do the endocardium, but he's a smart cardiologist, and I let that go. And then you have your precordial leads, V1 through V6. Why we use 12 leads? It allows us to obtain multiple views of the heart at one moment in time. It facilitates a better visualization of the abnormalities or the normalness of the left heart. To view the right side of the heart, you must move V3 through V6 over, okay? Now the most important thing is some people want to move V1, V2. Those stay the same, okay? You just move 3 through 6 to the exact mirroring side of the heart. The frequency that you guys would do a right-sided heart in the field is very rare. I will talk about, though, moving V4 over in an inferior to see left ventricular or right ventricular wall infarct. And we'll talk a lot about right inferior or the inferior MI pattern and kind of why it's different. Okay. So again, V1, V2 needs to stay the same. Systematic approach to 12-lead EKG interpretation. Pearls, don't rush to judgment. We all see things that jump out and we focus on that and then we can miss stuff. It's important to take a snapshot, see what does pop out. This just vibrated at me.
Time's up.
Okay. Thank you for coming today. It is important to take a snapshot, look at it really quickly, see if there's something that pops up that needs immediate attention, but then spend a couple moments looking to see if there's anything else going on. It's hugely important to be systematic. If you do it the same way each time, it's going to become easier and easier and ingrained, and you're less likely to miss things. You know what? Everyone's going to screw up EKGs. I work in a cath lab. I screw them up. I get schooled by my cardiologist more times than I care to admit. We all have to learn from this. And as I said, you put 3 cardiologists in a room, they're going to argue over something. And again, the overlying theme for today, treat the patient, not the paper. So, first step, snapshot. Look at the overall picture. What jumps out to you? Is it Brady? Is it a 3rd degree? VTAC? Does it have a pulse? SVT? Bundle? Those are pacemaker. Are those the things that jump out at you? If the patient is compromised, treat those things. You're going to generally not see that on your 12 lead. You're going to see that, on your rhythm strip. But treat those things and then kind of go from there if they're compromised. If not, evaluate the EKG further if you have time and the patient's condition allows. Step 2, we're going to look at the heart rate and the rhythm. Is it fast? Is it slow? I don't expect anyone to get calipers out. It's unrealistic. The way I work, is it fast? Is it slow? Is it not even present? Is it organized? So I like the 300, 150, 175 kind of thing, just counting boxes really quick. So that's a good way. If it's really fast and I see it's 1 box to 1 box, I know it's 300. If it's 2 boxes, it's vibrating at me again. If it's 2 boxes, I know it's 150. 3 boxes, 100. 4 boxes, 75. So a really quick way of kind of getting a calculation. One of the things I was talking to my wife, she was looking over this PowerPoint for me, looking for grammar errors. And she pointed out on some of the peak T waves, the first, and I do this too, is I love when it's saying I have a 250 heart rate. Because the machines aren't that bright. If it's tall enough, it's going to count it as a QRS. The easiest and smartest way, and I don't know if your monitors do it, but every pleth is going to give you a heart rate off the pleth. So whenever I have a really high heart rate that it's reading because I'm quickly looking at it, I automatically go down to the pleth to see if it's correlating. Because this is electrical, your pleth is truly mechanical. So no matter what's going on here, your pleth is telling you what your mechanical is. And you can do a lot just off a pleth. If your EKG breaks, you can tell a lot from a pulse ox. Okay? When I used to go into MRI, where we couldn't take a lot of machines, I worked off a pleth. I got a pulse ox, and I could tell a lot about their heart rate based on that. If it's sinus, not sinus, if I'm skipping beats, all those kind of things. If I have PVCs, you can tell a lot. So if you have time and you're in the back of the bus and you're, just screwing around wasting time. Watch when they're having PVCs. Get used to what that pleth is doing and how it's different. And if you lose your EKG, your wires somehow get cut, something, it's a nice lifesaver. I use it a lot when I'm in doubt of what's going on with the heart rate. Okay, irregular heart rate, in a 6-second strip, count the QRS complex and multiply times 10. Real simple for irregular. Axis, these are my favorite little guys. We're going to skip it. I personally do not use axis in the field. Okay, talking to my cardiologists, they use it for certain things, but overall, a lot of people just glaze over on axis. And personally, I don't feel that in the vast majority of cases that it's that relevant in the field. Okay. Now we're at step 4 is intervals. So what's the PR interval? Is it greater or less than 200 milliseconds? QRS complex. Is it greater or less than 120 milliseconds? QT, again, R to R, is it less than half? Boom. That's the simple way. We don't have time in the field to do a lot of things. Luckily, QTC is calculated when we do EKGs, 12 leads. So always look at that though. It's a nice thing to know. Step 5, because I'm a ginger, I had to put that in there. P waves. P wave analysis is critical for rhythm determination. Is there a P wave? So is it junctional? Is it AFib? The lack of a P wave tells you a lot. Is there a QRS with each P wave? If you got a P with every QRS, guess what? You got sinus. More P waves than QRSs? Is there a prolonged PR interval? Is it progressing and then dropping? The P waves are hugely important in determining what their actual rhythm is. Morphology again, so we know that widened is left, peaked is right, inverted is coming from somewhere other than the SA node. I found a bunch of people that did tattoos. So I have a little theme here yet. I love the next one coming up. It's coming up sometime. So QRS complex. Is it the width greater than 120 milliseconds in V1? Then determine right or left. Is your arm down, is your arm up? Boom. So is it left or right? If you have it in all your leads, palpate the chest. See if they've got an implantable pacemaker. Okay. Kind of a rule, I kind of do this on all my patients that are cardiac. As I go up and talk to them, I put my hand on their left side of the chest and just touch it right there. I'm generally going to tell. Vast majority, I'd say 85% of all pacemakers I put in are on the left. And the reason initially was that people were shooting shotguns and those kind of things, and they didn't want, and most people are right-handed, so the things that they put up to their shoulder are generally on the right. The reason that we would put a pacemaker on the right is because of some kind of venous irregularity. So what we'll do is when we're putting in pacemakers, we'll shoot contrast up, see the kind of venous flow that we can get the wires down. So once in a while we go right, but I'd say 85–90% of the time we're going left. So if you throw your hand on the left side of the chest wall, you're generally going to feel the pacemaker, and they're getting smaller and smaller. Okay, QRS, is there a Q wave present, and is it pathological or physiological? What is the definition of pathological?
So pathological, as far as the amplitude, so your depression needs to be 25% to a third of what your QRS is. And then as far as the width, we're looking for wide. So let's say you said like 120?
40 milliseconds.
40 milliseconds is the number.
And then the other important facet, since I've got 3 other people, anyone? Remember, you need to have it in more than one lead, so concurrent leads. Okay. You can have a Q lead, wave in one lead. I'm not as impressed if I got concurrent leads. It's more clinically important to me. Increased voltage, which we will talk about, ventricular hypertrophy, and more later. This is the one I love. This ginger put it on his leg. So I had to cut it out because it got a little high on the slide, so I had to trim it up here. I was like, whoa, buddy. But significant is greater than 1 millimeter elevation. Again, when I was talking about the doc, that's anything other than V2, V3. And remember, and we'll talk about pericarditis, but near global ST elevation, is it pericarditis or is this going to be a really bad transport? So, and the patient's clinical condition is going to tell you a lot about that. Your assessment is going to be more important than the EKG with pericarditis, in my opinion. Getting those facts. What's it feel like? What makes it better? What makes it worse? All those kind of things. ST depression can be ischemia versus a lot of other things. Okay, so we're going to move on from that. T waves. Inverted. Remember, that's most likely ischemia. It can be non-specific. I will talk more later about doing repeat EKGs and how important they are. But if we do repeat EKGs and we see a progression of depression, that's clinically very important to us. And also it can tell us if they've had previous, new versus previous cardiac events. Remember, peaked T waves is indicative of high potassium. I talked about this before, is you generally do not see it with chronic, you will see it with new onset. You know, that's not a hard and fast rule, but I feel pretty comfortable saying that. And then what's your overall impression? Does it correlate with the clinical picture? You know, when we have these postmenopausal women, you know, the clinical picture can be so varied and so out there. I've had people with indigestion, lower back pain, leg pain that have 100% LAD, you know, so anyone postmenopausal, my index of suspicion for a vast number of conditions is elevated. You know, I just had an upset stomach. Boom, I'm doing an EKG on it. I don't care because it's only paper. But if I'm missing this, I could not be doing the right thing for the patient. So it doesn't hurt to waste paper. The department will buy more, I promise. And then overall impression, do I have a differential diagnosis for this? Could it be A, could it be B? How am I going to determine that? Generally, it's going to be based off me, you know, doing a good H&P in round. Remember, look for horses, but beware of the zebras. There's some people out there that are always looking for zebras, and they're so focused on the zebras that they forget about the horses. So if it's a way out there, rule out the horses first and then move on to the zebras. And then do you know how hard it was to find a zebra and a horse in one picture? That took me like 10 minutes. Is there anything you missed? Just take one more look. You know, we all focus in and we're like, oh, I've got this. This is an inferior. This is that. But look at the whole picture one more time and just slow down for a second and go, oh, and you found something else, and it changes your whole clinical picture. And drug toxicity, you know, is this patient taking a ton of meds? Are they taking new meds? Is there anything that started in the last 3 weeks? Electrolyte abnormalities, and then we do get zebras, but you know, the zebras are fun. So this is a one slide on the steps of myocardial infarction. So all of us have lipid pouches that exist in the intima of our arteries. They have done posts on newborns, and they have lipids in their intima. So it's natural that we all have that. But over time, those lipid pouches can expand. They initially expand outward, okay, until they hit a level which they then are forced inwards. This isn't that big of a deal. But what the deal is when they rupture, okay, you cause a cascade effect. Okay, so again, the pouches, I've got ahead of myself, they start compressing inward and then they can rupture. And it causes an inflammation cascade, which involves the platelets, fiber, and all those kind of things, which is generally a clue. You know, we generally think that, you know, these 80% are the ones that are most at risk for rupturing. A lot of times it's the 10-20%, you know, occlusions of the arteries that are actually higher risk for rupturing. Don't really understand why, but the data is showing that it's these 80% are pretty stable a lot of times. Let's look at injury patterns. Okay, when I'm teaching new nurses in the ER or someplace, when people are looking at EKG, they have a hard time a lot of times correlating to where that is going at the heart. If you have a full-size 8x11 piece of paper, EKG, which I know you guys don't, you hold it up to your chest, you put the left side up to the right side of your heart and wrap it around, guess what? That is showing you exactly where the infarct is happening or the injury pattern. So if I got 2-3 AVF, which is right here, and I'm holding it up right to my sternal border, it's telling you it's the right side of your heart. Okay? If I've got a lateral going on, D5, D6, guess what? It's over here. So it's a good way mentally to incorporate the picture of the paper into what's going on in the heart. And it was very helpful to me. So, you know, anytime you got a new medic or you got someone you're trying to teach them, have them hold up an EKG to their chest and think about it. And this, I think really helps them understand where things are going on. Because if I got a septal, hey, look, septal's right in the middle. Okay? Even though I find the septal thing kind of a joke, and I'll talk about that in a minute. So inferior MI infarct. You have elevation. Remember, if we hold it up, it's the right side of the heart down here. It's 2-3 AVF. Okay. You can have. So here's an example. I just blew it up. There's your isoelectric line and your J point, and there's your elevation right there. Okay. So if I'm taking it, my isoelectric line is right there. I know I'm kind of shaky. J point, boom, right there, and do your measurements, and that's some nice SV elevation. You can have possible reciprocal changes in lead 1 and AVL. I went round and around for a couple years because I couldn't comprehend reciprocal changes. It didn't make sense to me. And the best way it's explained to me is that reciprocal changes are kind of a retrograde picture of that elevation. Okay? So, but it still doesn't make 100% sense to me why it's overriding the existing, you know, electrical activity that I'm seeing. I've come to the conclusion, I don't care. If I see it, I see it. I don't even need to understand why. And when you're seeing an injury pattern of 2-3 AVF, and you got reciprocal changes, guess what? It's money. You know you've got a STEMI going on. If I don't have reciprocal changes, it doesn't mean I don't have a STEMI going on, but what else? You know, could it be? Could it be pericarditis, those kind of things that I'm not getting reciprocal changes. So, inferior infarct, 40%, excuse me, 40 to 50% of all infarcts are from the right coronary artery. 40% of those have right ventricular infarct or involvement. Okay, the reason being, if you look here, you have your circumflex artery coming down here, and you have your right coronary artery. You have what's called right and left dominance. Okay, what that is the right coronary the dominant artery on the base of the heart, or is the circumflex? Okay, but the vast majority of them are going to be the right coronary, like 80%, and about 20% are going to be the circ. 20% develop bradycardia due to SA node involvement. This doesn't show it very well, but the SA node comes off right here with a branch feeding it. Right there is illustrated as the right coronary artery, and then 20% is the circ. What's the big deal with inferiors? You know, why is everyone like, oh, inferior, inferior? Let's talk about it. It's the right side of the heart. It is your electrical powerhouse. It's where everything's coming from. Okay? It's your right ventricle, which provides your preload to your heart. People in AFib, I think the number, and don't hold me tight to this, it's like 15% to 20% of your cardiac output comes from your atrium. Okay, so people in AFib, they've already lost 15, maybe 20% of their total cardiac output because they're not preloading that Starling's curve of preloading the heart, getting the increased contractility. We'll talk more about Starling's in a bit. Oh, we'll talk about it now. So Starling's curve, is anyone familiar with it? Okay, some are, some aren't. So Starling's curve is that when you have increased stretch of your myocardium, your cardiac tissue, your ventricle, you will get increased force of a contraction. So the more filling and stretching you have, the stronger your ventricle will contract and eject blood. So when we knock out the atrium, for example, we're not pushing that blood and loading and stretching the ventricle. So we're going to have a decreased ejection fraction. Ejection fraction is how much blood we push out of the heart with each beat. Typical EF is what we call it in the hospital, is about 65%. So we only eject 65% of the blood that's in the ventricle at any one time. Okay? So then we drop that by another, 20%. So say it's 100 mLs in there, and we eject 65, we drop another 20%, we're down to 40 mLs with each contraction that we're actually, ejecting out. Again, this is a good example except for one thing. So this is, right here, the branch that comes off. You can see this is right where it starts, okay? It comes off and feeds the SA node. Real quick, who knows when the coronaries fill? Is it on systole or diastole? Diastole, correct. So this diastole, what it is you eject because your ventricle's coming out right here. You're ejecting out into your aorta, and then as the valve closes, then the coronaries fill. But you can see if you have a really high occlusion or stenosis of your right coronary artery, man, you've knocked out everything. You've knocked out your SA node, they're going to be bradycardic, they're going to be all those kind of things. And then you have coming down here, which this isn't really where the AV node is, it's kind of over here. But for some reason, someone drew this picture and it's become the gold standard, even though it's wrong. So I went through like 30 different pictures trying to find a good example, and they're all looking like this. But all the right coronaries I look at, talking to people, it always comes off right about here. Okay. Again, we talked about the conduction is all coming from the right side of the heart. So there's your SA node. You're at risk for bradycardia is from there. Your AV node, you're at risk for second and third degree blocks, because it's fine that the SA node's kicking away, but if you don't have the conduction down there, because the AV node has been knocked out because it's ischemic, then you're going to have the risk for second and third degree blocks. Determining right ventricular infarct. We talked about moving V4 over and making it V4R. If you have ST elevation in V4R, you got right ventricular involvement, okay? So in that case, you're going to have to be judicious with your nitro. You're going to make sure you have plenty of IV access. You're going to preload them with fluids, all those kind of things. Nitro isn't, and I don't know your policies, I'm not trying to override your policies. Nitro isn't contraindicated, but use it judiciously, okay? And you got to think that sublingual is 0.4, micrograms. That's 400 micrograms. That's a lot of nitro. I don't know if you guys do drips. Are you allowed to do drips? No. Okay, then never mind. But drips are something to consider because it's a lot less. You're starting at 5 mics per minute. Okay? And it's quick on, quick off. I can turn it off, boom, and I can be done where that 400 mics is in there for a while. Okay? So again, as I said, judicious use of nitro. Preload the patient with fluids, generally 250 mLs minimum. Large bore IVs, and prepare for dysrhythmias. These are the people that I automatically slap pads on. As soon as I see inferior pads are going on. Because it's much easier to do it now than to do it during. So, the normal physiological response to nitro administration. We give nitro. It dilates, it decreases my preload. Starling's curve up here, less cardiac stretch. It decreases my blood ejected from the ventricle, my EF, which decreases my blood pressure. The body compensates by increasing the heart rate and increases vasoconstriction to kind of try to compensate for that decreased cardiac output, but then increases my preload and improves my blood pressure. So that's how our body normally deals with it, okay? When we're giving nitro to an inferior, again, it's all the same in the beginning: decreased preload, decreased cardiac stretch, decreased ejection fraction, which decreases my blood pressure. But what if I have bradycardia? What if I have right ventricular infarct and I got hypokinesis there? The body isn't able to compensate for that nitro, okay? I do have vasoconstriction to some extent, but I'm giving a vasodilator, so I'm kind of negating that, okay? The hypokinesis. Hypokinesis is low movement. You know, if I have a hypokinesis of the right atrium and ventricle, guess what? I can tank them. Their pressures are going to go, you know, into the floor. So, again, preload your patient with fluids, and be smart about your nitro. Okay. And is morphine more appropriate? Possibly. Avoid the nitro. It's a clinical decision. I'm not scared to use it, but I make sure I have access, and I have good access, and I got fluids. And I'm going to generally preload because I'd rather get them up a little bit than dilate them down. The other thing is, when I came from ER, I was very focused on getting them pain-free. Okay? Pain-free, pain-free, pain-free. Pain-free is nice, but the thing that makes the difference is getting the coronary open. You know, and that's kind of the mental mindset I had to go away from in cath lab. Is like, yeah, I can be really focused on that pain, relieving the pain, but getting them as quickly as I can to the hospital so we can get the coronary, and early activation is more important than pain-free sometimes. I'd rather have the patient stable and hurting than unstable and not hurting. So that's kind of the approach I come from, and it was a mindset shift. Okay, lateral infarcts. We will have ST elevation in lead 1, AVL in 5 and 6. If you hold up that EKG to your heart, you think that lateral is over here. You know, that lead 1 kind of comes in, is weird, but it kind of wraps around, so it makes sense. And AVL, remember that that's that kind of, it's looking, AVL is looking up through the left ventricle. Okay? You can have possible reciprocal changes in the inferior leads. In a lateral, it's generally an occlusion of your circumflex artery. Okay? It's only 10% of all MIs. Not very high. Inferior is much higher. So, and you can see, if you look at this coronary, if you're holding up that EKG, here's the sternal border, or here's the sternal border, the paper's wrapped around, you can totally understand why that's the circumflex that's doing the elevation in V5, V6, and lead 1. Okay? Septal MIs. Elevation in lead V1, V2. If you look, this picture doesn't show just lead 1, or V1, V2. I've got lead V3, a little bit in V4. Okay? I don't know why they did this, and I'll show you in a second why it befuddles me that they even call it septal MI. Okay? There are no reciprocal changes with that, even though I have possibly some reciprocal changes here. Okay? Septal MI is occlusion of the proximal LAD. So if I'm looking at that EKG and I have 3, 4 kind of going on, why would I just have V1, V2? That's what doesn't make sense to me, because I got downstream occlusion going on here. You know, it's very rare. But remember, textbooks and reality. I'll give you an example. I had an individual that went to a festival in the desert, for HIPAA reasons I'll be generalized, who was a pilot. He was carrying gas cans to his airplane, like a mile away, developed some chest pain. Instead of going to the clinic at this festival, he decided to fly himself in. Okay? He decided to bypass Reno, because I think the landing fees were expensive. This guy was cheap. He flew into Carson. He paid the mechanic $5 to drive him to the hospital. Okay? He had elevation in only V2. And it's pretty benign. But because we did repeat EKGs on him, we saw that it is an evolving, ST elevation. And he had a 99% LAD, only in V2. So reality from paper, people are different, the way they present. But it just doesn't make sense to me that if I have a proximal LAD, that I'm not going to have involvement of V1 or V3, V4 kind of thing. Okay? Again, I was talking about the downstream injury. Anterior lateral. Okay? In anterior lateral, we've kind of got the whole left side of the heart involved. So you take the anterior, remember with anterior we had 1 AVL, and then we had 5 and 6. With the lateral, now we have involvement of V2, V3, and V4. Okay. You can again have possible reciprocal changes. So left side of the heart, the reciprocal changes are the right side of the heart. In this, you have the occlusion of the LAD and possibly the circumflex. The more leads that are involved, the more likely you're getting into a left main issue. Okay, so the more leads that are involved, the higher, the more proximal the occlusion is, the sicker that you need to suspect them of being, obviously. And make sure that the clinical picture correlates. Again, treat the patient, not the paper. Again, this is now just throwing in the V1, V2 leads into it. You can see that I've got kind of global left-sided elevation. Again, to me, this would be more suspicious again of the left main. Again, left side of the heart, reciprocal changes on the right side of the heart. Okay. And anatomical relationship to septal, lateral, and anterior injuries. Septals rarely occur without lateral and anterior. The LAD, right here, so we've been talking about this, supplies V1 through V4, okay? So V1 is more proximal, V4 is more distal. Circumflex is, everything we've talked about, is V5, V6 over here, lead 1 over here, ABL kind of thing. Again, I'm just reiterating, the more you see ST elevation, the more likely you got a left main, and my life is going to be very difficult in the cath lab, and they're probably going to go to get a cabbage. Serial 12 lead EKGs. They're hugely important. I will always, if I'm doing a flight, say I'm doing a flight from Urrington to Reno, I've probably done a minimum of 1 on scene or at the hospital and 2 in flight. And I want to be able to show that progression. If I'm going to Renown, I'm going to Carson, wherever, I want to be able to show the serials, because that's hugely important to the cardiologist. One is to see if my intervention would have been effective. Okay. 2, to be, because sometimes we'll TPA at Urrington, for example, and if I'm shown a resolving. If I'm not shown a resolving, they're going to be like, hey, he's got TPA but not resolving, straight to the cath lab. But if it's the subtle things like that person who was at the festival in the desert, that just subtle increasing ST elevation, they're going to be like, yeah, let's go. So you're going to help us decrease our delay to treatment by showing us this evolving clinical picture. Anytime anything changes with my patient, I'm going to be hitting 12 lead. Because if they start developing more chest pain, boom, I do a 12 lead and I show that I've got ST elevation going on with that increasing pain. Guess what? Ticket's been punched, they're off to cath lab. And it helps detect those subtle changes like I was talking about. And remember, it's only paper. Print it up. We don't mind having extra paper. All right, you guys like a break? Yeah. Okay.